Hi everyone. This video is on neuraxial blocks, spinal and epidural anesthesia. This is a very important topic and you will be practicing these techniques daily. So I have divided this topic into three parts because it's a big topic. And I advise you to please please go through all of them because they are very important. You can increase the playback speed if required, but do see all of them. So these videos are still in very brief and I'll be uploading the larger version, the complete version very soon. The contents of this video will be comparison of spinal and epidural anesthesia, the anatomy, the preoperative preparation. This video will cover these three topics, and in the second will be spinal anesthesia and the third will be epidural anesthesia. So first let's compare between spinal and epidural anesthesia. So in spinal, the local anesthetic solution is injected into the cerebrospinal fluid. It is contained within the subarachnoid space, that is the intrathecal space. As you must have seen during your MBBS postings, that the lumbar puncture, when we had to take the CSF sample. So it is the similar technique, just that in this we deposit a drug into that space. So the local anesthetic solution is deposited into the cerebrospinal fluid. And in epidural anesthesia, it is injected into space that lies within the vertebral canal but superficial to dural sac. You will understand all about it very soon, later in the slides. So it is epidural. It is outside the dura. And in the caudal anesthesia, it is a type of epidural anesthesia only. And the caudal epidural space is through the sacral hiatus. We'll learn about this in detail. In the spinal, the drug is given at the lumbar region below the spinal cord termination. The spinal cord terminates at L1. So we give the drug below it so that we do not inject it into the spinal cord. And in epidural, it is injected at various levels along the neuraxis. The advantages are that in the spinal, it takes less time to perform. There's a definite endpoint. No? There's a clearly defined endpoint, which is the CSF. So it takes less time to perform. It is less discomforting to the patient. We use less local anesthetic and there is more intense sensory and motor block. Whereas in epidural, there is decreased risk. Advantages is there is decreased risk of PDPH. PDPH is post-dural puncture headache. There is lower incidence of systemic hypotension. There is ability to produce segmental sensory block. We have greater control over intensity of sensory anesthesia and motor block achieved by adjusting the local anesthetic concentration. And also we can titrate the block to the duration of surgery. Because in epidural anesthesia, we leave a epidural catheter inside, which is a very thin catheter. And through it, we can give the drug later on also for post-op pain control. And it is also used for labor pain, for obstetric pain. Okay. So now we come to anatomy. So now we'll understand something about the anatomy pertaining to these two blocks, spinal and epidural. In this, we'll learn about the vertebral canal, ligaments, spinal cord, meninges, spinal nerves, the subarachnoid and epidural spaces, and the blood vessels. So first we come to the vertebral canal. So vertebral canal, as we all know, that it is on our backs, it is the spinal canal. It is the bony structure extending from foramen magnum to sacral hiatus. Okay, so it is extending from foramen magnum to sacral hiatus. Okay, and so it has four curves. This vertebral canal has four curves. Two curves are primary and two are secondary. The primary curves are with which a baby is born with. So they are this thoracic curve, thoracic kyphosis, and this sacral curve, sacral kyphosis. Okay, these are primary curves. And then there are two secondary curves which are developed later in life. This cervical lordosis and lumbar lordosis. Both the lordosis comes later. Okay, so cervical lordosis comes when the child starts holding neck around 3 months. And the lumbar lordosis comes when the child starts walking around 1 year. So all the four curves are there by the end of 1 year. And out of these, the thoracic and the lumbar curves, the thoracic kyphosis and the lumbar lordosis are important in the distribution of our local anesthetic because we give the drug here only somewhere. We'll learn about this. And this vertebral canal, it gives protection to vulnerable neural structures. The spinal cord and the nerve roots are safely inside this bony canal. And but this, this bony canal offers barrier to advancing spinal and epidural needles. So we have to practice it daily. The architecture. Now the vertebra. Vertebra are the building blocks of the vertebral column. They are stacked upon one on top of other. So see, it is very important to learn about the this vertebra. This is the anterior vertebral body, as you can see. So this is the anterior vertebral body, and this hole posteriorly is the posterior arch. Okay, so this is the anterior vertebral body. This is the posterior arch. So in this posterior arch, there is this laterally we have two cylindrical pedicles, as you can see, attached to the vertebral body. So there are these two cylindrical pedicles, and there are these two flattened lamina, and then this is the spinous process posteriorly. So how you can learn this is that pedicles are laterally, P is not posteriorly, pedicles are laterally, and L is not laterally, L is posteriorly, so it is opposite. So lamina is posteriorly. Then connecting the two lamina, we have this transverse processes, okay, connecting two lamina, and the spinous processes by the junction of the two lamina. The transverse processes by connection of the lamina and the pedicle. On the lamina, there are these notches on the top and the inferior part. So it forms the superior articular process, and similarly there is inferior articular process. Now these are stacked upon each other and they form the facet joints. Okay, so this is the vertebral body, this is the posterior arch. Now this hole, when stacked upon each other, they form the tubular lumen, and this is the vertebral canal. This is the vertebral foramen through which the spinal cord goes. Now, as you can see, this is laterally, we can see this is the vertebral body and this is the posterior arch. So this is the lamina. Okay, so lamina is notched superiorly and inferiorly. See, lamina superiorly also and inferiorly also. And as you can see that these notches, they form the upper and the lower lamina, they form the intervertebral foramen through which these spinal nerves emerge. Okay, so through these intervertebral foramens, the spinal nerves emerge, and these are the facet joints I've already told, formed by the superior articular process and the inferior articular process. Okay. Now the vertebrae. Now we know that there are 33 total number of vertebra, but out of those 33, there are 24 true vertebra, because there are 7 cervical, 12 thoracic, 5 lumbar, and then these are the false vertebra because they're not true. There is this bony sacrum which is formed by the fusion of 5 vertebra, and then this coccyx which is formed by the fusion of 4 vertebra. So these sacrum and coccyx are distal extensions of vertebral column. Now as you can see, these are the lumbar vertebra stacked on top of each other. These are thoracic vertebra. See the angles of the spinous process. These are perpendicular, but these are angulated inferiorly. So we have to take care that when we are putting the needle, like the epidural needle, in the lumbar space, we can go perpendicular, but here we have to take this angle. Okay. Now the sacrum. Now sacrum is the wedge-shaped bone. Okay. It is the wedge-shaped bone. As you can see, it is formed by the fusion of the 5 sacral vertebra. 1, 2, 3, 4, and 5. And the opening between the unfused lamina, the opening between the unfused lamina of the 4th and 5th sacral vertebra, as you can see that the lamina of this and this vertebra are not fused posteriorly. So there is this space left, which is called the sacral hiatus. And through this space, we enter during caudal anesthesia, while we give caudal anesthesia. So this is that space, and it is actually absent in 8% of individuals. So in those 8% of individuals, we cannot give caudal anesthesia. However good the experience and skill of the anesthesiologist be, but if there is no sacral hiatus, then we cannot give the caudal anesthesia. Now the surface landmarks, as you can see, that there are certain landmarks we have to take care while we are giving the anesthesia, because it is the skin we are seeing and we cannot see it properly, the vertebra. So there are certain landmarks through which we can estimate, we can predict that this space can be here. So the most important is this Tuffier's line. Tuffier's line. So it passes through this is a horizontal line which passes from the topmost part of the iliac crest. Okay. So this line, it passes through the body of L4 vertebra. So above it is the L3, L4 interspace, and below it is the L4, L5 interspace. So it passes through the L4 vertebra. Now here, as you can see, the C7 is the most prominent bony knob in the neck. It is the C7. Then the angles, the inferior angle of the scapula, the line passing through the inferior angle of the scapula passes through T7 vertebra. Okay, T7, T8 interspace. And so you can come down and see here that this 12th rib passes through the L2 vertebral body, 12th rib. And this PSIS, posterior superior iliac spine. Now these are dimples on the near the buttocks of the patient. So this PSIS, it passes through S2, lower part of S2 vertebra. So it is usually where the dural sac finishes. It ends. So you can give the spinal only till this level, because below it there is no CSF. Now we come to ligaments. Now there are certain ligaments which are there, which helps to guide the insertion of our needle. So as you can see, this is the vertebral body and this is the posterior arch. So anterior to the vertebral body is the anterior longitudinal ligament. Okay, this yellow one, and then posterior to the posterior to this vertebral body is this posterior longitudinal ligament. Okay, and this is the spinal canal. This is the vertebral canal where the spinal cord is there. Okay, and so you can see that the anterior boundary of this spinal canal is formed by posterior longitudinal ligament, and it is not formed by anterior longitudinal ligament, because it is anteriorly to the vertebral body. And this you can see that this is the spinous process, and connecting the tips, only the tips of these spinous processes are supraspinous ligament. Connecting the tips only. Then connecting this interspinous processes, in between the spinous processes, there is interspinous ligament. So these are the supraspinous ligament. This is the interspinous ligament. These two ligaments are only in the midline. They do not extend laterally. So they are only there in the midline. And as you can see, now this is the ligament which connects the lamina of the upper to the lower. This is the ligamentum flavum. Okay. So this is the ligamentum flavum, and this is present in the lateral part also. So when we are inserting the epidural or the spinal needle, if we are entering from the midline, then we encounter supraspinous ligament, the interspinous ligament, and the ligamentum flavum. But if we go little paramedian, by the paramedian approach, then these two ligaments will bypass, will pierce the skin, subcutaneous tissue, and then directly the ligamentum flavum. Now this is also to show the ligaments. As you can see, this is the anterior longitudinal ligament. This is the posterior longitudinal ligament. This is the spinal canal. These are the supraspinous ligaments. This is the interspinous ligaments. Then these are the ligamentum flavum. Now, if we talk about the spinal cord, as you can see that the spinal cord is inside the vertebral canal. It starts at the level of the rostral border of the medulla, and it is till this sacrococcygeal ligament, this sacral hiatus. Okay, so this blue one is the cervical part of the spinal cord, this green is the thoracic part, this yellow is the lumbar part, and this orange one, it is the caudal most. and it is known as the conus medullaris. As you can see, the conus medullaris. So the spinal cord is ending at conus medullaris. It is at L1 vertebra. The lower at birth it extends till L3, but as there is growth, the spinal cord grows less than the vertebral canal and it ends at lower border of L1. So conus medullaris, and then the nerves have already emerged. So the nerves have these nerves, the corresponding nerve emerged from the corresponding intervertebral foramen. Okay, so here what happens is that the nerves becomes longitudinal to the axis of the vertebral canal, and it forms the cauda equina. As you can see, cauda equina. So this means tail of the horse. So it looks like the tail of the horse, and so it is extending downwards and it is coming out through their respective intervertebral foramen, and then the dural sac ends at S2. At S2, lower border of S2, the dural sac ends, and then it is only the pia mater which continues as the phylum terminale. So pia mater continues inside also as phylum terminale internum, and it is covered by this dural sleeve at S2, and then it continues at phylum terminale externum after this. So if we see the meninges are the coverings of the brain and the spinal cord. We all know that, right? So the outermost is the dura mater, this black one. This green one is the subdural space. The arachnoid matter is this blue one. This whole blue part is the CSF, cerebrospinal fluid, inside the arachnoid matter. And pia mater runs just adjacent to the spinal cord, as you can see, the pink one. So the dura mater, it originates at foramen magnum. It is extension of inner meningeal layer of the cranial dura. So as we know that inside the brain, inside the cranium, the dura is two layered, but the one which extends downwards is the inner meningeal layer. And so the dura mater is not communicating with the cranium. It is only one layer which is coming down. And caudally, it terminates between S1 and S4. As we have seen earlier, it was still S2. It is tough fibroelastic membrane, structural support, and fairly impenetrable. Because, you know, the epidural, it is outside this dura. It is impenetrable, so the epidural does not enter the subarachnoid space. It acts as a barrier. So the arachnoid matter, it is major pharmacologic barrier preventing movement of drug from epidural to subarachnoid space. So arachnoid is pharmacologic barrier. The drug is not entering from the epidural space to the CSF. And then we have pia mater, which is highly vascular, closely applied to spinal cord. As spinal cord tapers to form conus medullaris, as we have seen, pia continues, as you can see here, conus medullaris, the spinal cord is over, but the pia mater continues at as phylum terminal internum, and then after the dura ends at L2 as phylum terminal externum. Okay, and then it is attached to the posterior wall of coccyx. Now the spinal nerves. Now the spinal nerves emerge from the dorsolateral root of spinal cord. The dorsal nerve root emerge. From the ventrolateral portion of the spinal cord, ventral nerve root emerge. Now after the nerve root, there is dorsal nerve root ganglion also. Now this dorsal part is responsible for sensory input and this ventral for motor input. This we have read earlier in our medicine classes. Okay, so now these two roots combine to form spinal nerve in the intervertebral foramen, and then they emerge. So as we know that there are 31 pairs of spinal nerves. Okay, so there are 31 pairs of spinal nerves, 8 cervical, 12 thoracic. Now the vertebra were 7 cervical, but spinal nerves are 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, 1 coccygeal. As nerve pass through intervertebral foramen, as we have already discussed, they are encased by dura, arachnoid, and pia. But when they become nerve, now they are termed as epineurium, perineurium, and endoneurium. So these are extensions of the meninges only, but now they are called as epineurium, perineurium, and endoneurium. Now, onset of epidural block occurs by blockage of sodium conductance in this region only, in the intervertebral foramen. Okay, so now there are 7 cervical vertebrae, but 8 cervical nerves. Now, the first cervical nerve passes between occipital bone and posterior arch of C1 vertebra. Okay, now the first cervical nerve, it passes between this skull bone, occipital bone, and the posterior arch of C1 vertebra. But the corresponding ones, the next ones, all they pass through the lower ones. So the 8th cervical nerve passes between C7 and T1. T1 will pass between T1 and T2. T2 will pass between T2 and T3. Okay, so below. Now, if we talk about the dermatomes, these are the area of skin innervated by each spinal nerve. Now, these are important because certain surgeries require certain levels. So, we can see the thoracic nerves innervate the thorax and the abdomen, and the lumbar and sacral nerves innervate the legs. See, as you can see, L1, L2, L3, L4, L5, S1, and here also S1, S2, S3, here near the sacral area. So, you can see, so like in surgeries, like the T1 to T4 are cardioaxillary fibers. So T4 corresponds to nipple area. So we check after giving the anesthesia that what level we have achieved. Like in certain surgeries, T4 level is required. And in certain surgeries, T10 level is required. T10 is at the level of umbilicus. L1 is inguinal ligament. So we correspond the dermatome with our knowledge of the various landmarks, and we check which level we have achieved, and we adjust the patient position and the level where they're giving the drug to achieve that particular dermatome. We'll be learning about this daily in our OTs, and we'll get used to of which level we have to achieve. So the subarachnoid space is between the subarachnoid matter and the pia mater. This we have learned, the blue space in which the spinal cord is bathing. It contains CSF, which is formed by the CSF is formed by choroid plexus of lateral, third, and fourth ventricle. Okay, and cranial nerves can be blocked by local anesthetic migrating into CSF above the foramen magnum. Now this subarachnoid space, it is continuous between the brain and the spinal cord. It is continuous, the head and the vertebral canal. So there is a chance of high spinal anesthesia if we do not check it properly. If we give larger amount of drug, the position is not proper, then there is this risk. In the epidural space, it is not continuous with the head. So it is between dura and the wall of vertebral canal. It is irregular column of fat, lymphatics, and blood vessels. The boundaries are very important in case of epidural space. Cranially, topmost, we have foramen magnum. Caudally, there is sacrococcygeal ligament, which we pierce during caudal anesthesia. So that is the caudal end, sacrococcygeal ligament. Anteriorly, as we have already discussed, there is posterior longitudinal ligament. Posteriorly, there is ligamentum flavum and vertebral lamina, and laterally, there are vertebral pedicles. Okay, this we have seen. And see, this is the needle which is entering. So skin, subcutaneous tissue, the ligaments, and then we enter the subarachnoid space, the epidural space first. This is the epidural needle, so epidural space. Now, the epidural space communicates with the paravertebral spaces by intervertebral foramen. So yes, the drug is not going into the brain, but it can go into the paravertebral spaces. Now, the depth is maximum at L2 level, midline, which is 6 millimeters, and it is minimum at lumbar and the cervical enlargements, as we have seen in that diagram of the spinal cord. So it is 3 millimeters there. Now we come to blood vessels. Now the blood vessels, the arterial supply of the spinal cord, it arises from single anterior and two posterior spinal arteries. So anteriorly, there is only single artery, posteriorly two. This single anterior artery originates from vertebral artery and supply ventral motor portion. Okay, ventral motor portion. And the posterior are two emerge from cranial vault, supply dorsal sensory portion. It is posteriorly, so supply the dorsal part. And since there are two, so that is why the dorsal sensory part is less prone to ischemia, because there are collaterals also, and there are two arteries. Now there is this artery of Adam-Kivitz, which is also called radicularis magna. It is the largest anastomotic link. It arises from aorta in lower thoracic and upper lumbar, and it is critical to blood supply of lower two-thirds of spinal cord. Okay, it is a very important artery because it may be damaged during aorta surgery or when we do not put the epidural needle properly by the stray epidural needle. So it may cause bilateral lower extremity motor loss. It is also called anterior spinal artery syndrome. So anterior spinal artery syndrome is caused due to damage of this artery of Adam-Kivitz. And the venous drainage, it is very important. See, the spinal cord, the vertebral canal, it is drained by internal vertebral venous plexus, which drains into azygous venous system. Now, the importance of it is that, like, if there is any intra-abdominal pressure or tumoral masses, or if there is any pregnancy, then the mass can compress the inferior vena cava. Okay. When the IVC is compressed, there are engorged epidural veins. Now, the epidural veins are engorged, so two things can happen. Either when we are giving epidural anesthesia, we are inserting the needle, there is increased chance of accidental vascular cannulation. Okay, so the needle can enter the vessel, or because the epidural veins are engorged, so the epidural space become less, the effective space is less. So there is greater longitudinal spread of the local anesthetic. So we can have higher epidural anesthesia. Now, after this anatomy, we come to preoperative preparation. So for neuraxial block also, the preparation is same as general anesthesia, as we have already learned in the previous videos. And so we'll be routinely checking the anesthesia machine, the ambu, defibrillator, the anesthesia drugs, suction, everything we have to check like for general anesthesia only. And we also discuss with the patient about specific benefits and potential complications of block. We have to tell them that there are rare, very rare complications, but there are serious ones like nerve damage, bleeding, and infection. And then there are common ones, but are minor, so like PDPH, post-dural puncture headache. We'll be learning about this in detail. And we have to tell them that there's possibility of failed block. And during that time, we'll give some alternate anesthesia. So the indications of spinal anesthesia are surgery of lower abdomen, perineum, and lower extremity. So abdomen and below it. And the epidural anesthesia, same as spinal. And they're also used to supplement the general anesthesia in thoracic and upper abdominal surgeries. For post-op pain, we also use for labor anesthesia. And for cervical epidural anesthesia, we use for chronic pain also. There's certain contraindications in neuraxial anesthesia. The absolute ones are, if the patient is refusing, then we cannot give neuraxial block. If there's infection at needle puncture site, then we should not give because it is a sterile space inside. Then if there is elevated intracranial pressure, then we should not give neuraxial anesthesia because it can cause herniation of brain tissue. Then if there is bleeding diathesis, then we should not give. Okay, there can be hematoma formation, which can paralyze the patient. Then there are some relative contraindications like bacteremia. So if a patient is having bacteremia, then we can introduce the infected blood into the sterile epidural space. It can cause epidural abscess and it can cause meningitis. So we have to weigh the benefit versus risk. And if it has to be given, then prior to it, we have to give IV antibiotic. Pre-existing neurological disease like multiple sclerosis. So multiple sclerosis itself, in this disease, patient experiences remissions and exacerbations due to demyelination of peripheral nerves. And the local anesthesia toxicity also causes the same histopathology, that is demyelination of peripheral nerves. So it can be due to the disease, but the patient will say that it is because of your drug. So we won't be able to know the real reason. So we have to be cautious. Then there is chronic back pain. Now in chronic back pain, if we are giving these blocks, then the patient may relate the back pain later to our anesthesia, which was already there, but he may say that the pain now is because of that anesthesia. So we have to counsel them properly. Now, in case of cardiac diseases like mitral stenosis or aortic stenosis or idiopathic hypertrophic subaortic stenosis, now in these patients, we have to give the fluids very cautiously because after giving these blocks, there can be decrease in the systemic vascular resistance, and these patients might not tolerate that decrease in the resistance, peripheral vascular resistance. Then there are abnormal coagulation, and for this we have to follow the ASRA guidelines, which are important. We'll be studying that in a different video. So thank you everyone. This was the first part of this neuraxial block, and the second part will be spinal anesthesia. Do watch that video as well. Thank you.